Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health Center reporting for the week of February 1st, 2021. As health professionals rooted in Oakland serving some of the people most vulnerable to getting and suffering from COVID-19, we are here to cut through the noise to give you information you can use to make the choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Please submit your questions in the comments, by direct message, or by email to admin@rootsclinic.org. Now, we know that even though the pandemic is worldwide, the effects are very different depending on where you are. So we're here to give you up-to-date information about Alameda County and Oakland in particular. Alameda County now has over 74,000 COVID cases. The city of Oakland has over 23,000 cases. So here you can see daily case rates in Alameda County. And fortunately, as you can see, it appears that we reached our peak, and that happened in about the first week of January. And we seem to be coming down on the other side of this surge. Now, keep in mind that numbers for about the past week will continue to be updating, and so those are subject to change. As you can also see, we are still much higher than we were in the summertime surge, and certainly we do not know what is in store for us next. Typically, hospitalizations, ICU hospitalizations, and deaths trail behind cases. So no doubt that we are still seeing some of the impacts of our spike. We are now at 982 deaths from coronavirus. And while hospitalizations are coming down overall, hospitalizations in the ICU remain high, with about 100 people in the ICU with COVID-19 in Alameda County. Now, we've gotten a lot of questions about the variant and what it means and what we can expect. So we wanted to respond to some of those questions today. First thing to know is that viruses mutate. That is what they do. I've seen chatter and even gotten some questions wanting to know, does this somehow prove that COVID was made in a lab? No, it's not proved that at all. In fact, I would probably think it was more bizarre if COVID did not mutate. Basically, all viruses mutate, and this one is no exception. In fact, RNA viruses like COVID are known to replicate frequently, and with every cycle of replication, that is an opportunity for mutations to occur. As RNA viruses go, and especially with the amount of COVID infection all over the world, COVID actually mutates fairly slowly, so far at the rate of about 1 to 2 mutations per month. So on average, most of the specimens we are seeing have maybe 8 to 10 mutations compared to the original. So how does this happen? Well, mutations are basically just mistakes that happen spontaneously as the virus replicates itself. It's like you're typing out a code over and over, and sometimes you make typos. Sometimes you could switch a character for another, a substitution, or you might add something extra, an insertion, or you might miss something altogether, a deletion. And those are basically the kinds of mutations, substitutions, insertions, and deletions that happen in RNA replication. Now, COVID actually makes a protein that corrects a lot of these substitutions and deletions and insertions. So that is one of the reasons why COVID-19 mutates slowly. And we know, for example, that it mutates a lot more slowly than the flu virus. But sometimes these mistakes escape the correction process. And with millions of people being infected, there are lots of opportunities for replication and mistakes in that replication. This virus is replicating a lot. When the virus is undergoing replication and makes one of these mistakes, some of the mistakes actually make the virus more efficient at spreading. Some of the mistakes are irrelevant, but some of the mistakes make the virus more efficient. It could make the virus better at latching on to our receptors. It could make the virus better at entering our cells. And there are different pressures placed on the virus that can help create the conditions for this to happen and for these mutations to then continue to replicate. So what do I mean by pressure? This is basically what's called evolutionary pressure that creates conditions that help the virus be more successful or efficient. And there are a few ways that this happens in general with viruses, and a couple of theories with some evidence behind them about how this is happening with COVID-19 specifically. One is that mutations can actually happen inside of an individual who has a prolonged course of COVID. So, for example, in a person with a compromised immune system, let's say someone with cancer who is on chemotherapy, when they get COVID, they can end up with COVID infection for weeks, a prolonged or chronic infectious course of COVID. During that time, the virus can actually mutate in that person, and then that individual can spread it. And there are case studies of this happening with COVID 19. And this has also been reflected in our experience with other viruses where this happens, like with HIV. The other mechanism that's under investigation, I'm sorry to report, is human to animal and animal to human transmission. According to the CDC, we know that cats, dogs, ferrets, and other mammals can get COVID 19. Actually, we don't even know yet all of the animals that can get infected with COVID, but there have been reports of animals being infected with this virus all over the world, including zoo animals in many places here in the United States. There have been outbreaks at mink farms in Europe, and it does appear that the infection went from humans to minks and then back to humans. So whenever COVID jumps to an animal reservoir, it can evolve there and then jump back to humans. Another thing that can create pressure and that we need to be concerned about is the effect of treatments or medications that may be used for COVID. While we don't know the impact of this happening yet with COVID 19, it is something we need to keep an eye on, and I'll talk about that more in a bit. So, based on all the experience we have with other viruses and with other coronaviruses, I think it's important to first say that no one was surprised, or at least no one should have been surprised by variants. We fully expected to see mutations causing variants. We just never know when they might happen or how important they might be. In fact, most mutations, as I mentioned, are irrelevant. They have no impact. But with the volume of replications and mutations happening with COVID 19, something was bound to stick, and it has. I do want to point out that there was a mutation early on in the pandemic, and it was a mutation in the spike protein. It was called D614G. This mutation made SARS-CoV-2 more fit, and that variant spread quickly from Asia and then Europe and then here in the United States. And before we knew it, a variant that was actually unusual before March of 2020 was present in about 99% of the samples worldwide by the end of June 2020. It basically took over, and it has continued to be the dominant strain since then. After that, we didn't hear a lot about variants for a while until around the fall when we started to hear about variants in other parts of the world. And they began making their way to the United States in the wintertime, around the time of our surge. The most notable variants so far, the ones I'll talk about today, are ones that were first detected in the United Kingdom, South Africa, and Brazil. They all have that earlier D614G mutation and some new mutations, and they all appear to be significantly more infectious. They are more contagious. There's still a lot we don't know about the variants. What we do know so far, we know from a variety of different types of research. This includes research in the lab that's based on genetic sequencing and looking at the new variants. It's taking those variants and testing them against antibodies from the blood of people who have recovered. It's also testing against the vaccines. That's all happening in the lab. It also includes epidemiological research, which looks at how fast the infection seems to be spreading in particular areas, looking at different modeling and at contact tracing data where that information is available. Also, where possible, it is correlating the severity of disease with those found to have the variant. And all of this information is taken together to try to figure out what is going on and what it means. So I'll start with the UK variant, also called B117, which was first detected in the United Kingdom back in September 2020. It was reported in the United States at the end of December 2020, and it has now spread to over 50 countries. As I said previously, the average COVID specimen right now might have 8 to 10 mutations, where the UK variant had 23 mutations when discovered in the UK back in September. So this is a significantly greater number of mutations, which appear to be giving it an advantage in terms of spreading more quickly. There are many scientists who believe that the UK strain will be the dominant strain in the United States by March. Next is the South African variant, or B1351. It was first discovered in South Africa in October of 2020 and first reported in the US in late January 2021, and it has spread to at least 30 countries now. This variant shares mutations with the UK variant, but one unique thing about this variant is that it has 8 different mutations just on the spike protein, and we really don't like that for a couple of reasons. First is because we know that the spike protein is the part that clicks up with our receptors in our body, like a key to a lock. And some of these mutations may make it click up even better than it already does. Also, the vaccines target the spike protein, so that raises concerns about whether it will be able to escape the vaccine, and I'll talk about that more in a moment. One thing to know is that it only took a few weeks for B1351 to become the dominant strain in South Africa. It's that much more contagious, and it just kind of pushed the old variety out. The last variant I will mention is the P1 variant, first detected in Brazil in December. And in one particular area of Brazil, it is taking over and it's causing quite a bit of new infection and also death in a population that had already been hit hard with COVID-19 back in April. So this is particularly concerning because this was an area of Brazil where some experts thought that they had possibly achieved herd immunity through so much natural infection. They did sampling, and a large proportion of their population actually had antibodies to COVID-19, but those do not appear to be helping with this P1 variant. Also, locally, they're reporting that patients are coming in sicker with this wave of infection. So there's a definite concern that this variant is more virulent, that it is actually more deadly. This variant was reported in the United States in late January of 2021 in the Midwest, and we don't know yet if it's spreading here. So all 3 of these variants appear to be more contagious, and the variant first detected in Brazil may also be more deadly. But the fact that it spreads more easily is very concerning in and of itself, even if it is not more virulent, because COVID-19 is already so contagious. It's actually kind of hard to imagine this thing being more contagious than it already is, but it appears that that is in fact the case. And of course, as we have seen through the pandemic, when cases go up, hospitalizations go up, and deaths go up. So even if the variant itself does not make a person sicker, if it's not what we're calling more virulent, it can still cause more death just due to the increased numbers of cases, not to mention that ever-present threat of overwhelming our hospitals. We have detected some of these variants in the United States and right here in the Bay Area. But part of the problem, and why frankly we are operating a little bit in the dark here, is that we are simply not sequencing enough specimens. I hate to say it, but there is no coordinated strategy for what we call genomic surveillance, or sequencing enough specimens to stay ahead of what's going on. So we're operating in the dark. We're doing better here in California than in other states, but we are talking about a very small percentage of specimens actually being sequenced. So even though we're doing a lot of testing, we are doing very little sequencing, like less than 1% of specimens. Actually, nationwide, the last estimate I saw was that we have sequenced about 1/3 of 1% of our specimens. Some countries do have a national strategy for genomic surveillance, and they are certainly doing much better than we are in that regard. We have a ways to go here. So there's no doubt I am concerned about what we are finding, but I have to say that I'm even more concerned about what we are likely missing. Other things we need to know besides just the presence of the variants is how will these variants affect different subpopulations? For example, how will they affect children? Children seem to do better with COVID-19 because they have less of the receptors that the spike protein clicks up with. If the spike protein is mutating, what does that mean for them? Will they become more susceptible? We just don't know that yet. Also, what about treatments? Sadly, we actually have very few approved treatments for COVID-19 in the United States. But one of the treatments with some promise is called monoclonal antibodies. Monoclonal antibodies are made in the lab to mimic our antibodies specifically directed against the spike protein of SARS-CoV-2 and block that key from getting in the lock, which is our receptors. Well, we have every reason to be concerned and already have some data to show that the variants are defeating these treatments altogether. We also have reason to be concerned that these and other treatments, including any single drug therapy, could even help foster more variants. We've all heard of drug-resistant strains of different types of infection, and we don't know whether that will be in the cards with COVID, but it is something we need to be on the lookout for. As we have more infection and develop more treatments, we also create more pressure on this virus, which can then potentially create the environment for more variants. We need more information and evidence and experience here, but these are all real concerns. So what are the implications for the vaccine? So far, the UK variant does not appear to have evaded the approved vaccines in the United States. So that is good news. So even though the variant is more contagious, vaccination with at least the 2 approved vaccines here in the United States still appear to block the UK variant. Now, the variants that were first detected in South Africa and in Brazil are a little more concerning. The good news is that there is no evidence that any variant completely avoids the vaccine. So although it is possible that these vaccines may be less effective against the variant, it doesn't look like they will be made totally ineffective. This is really important. And it's happening because the vaccine actually starts off a whole entire immune response in our bodies that ends up creating antibodies against multiple places on the spike protein. The spike protein is actually 1,273 amino acids long. And when we get the vaccine, we make antibodies and a whole immune response to many places along that spike protein. So remember I said the South African variant has mutations on 8 of those positions. So most of us, when we get the vaccine, will be able to make an immune response against so many other areas of that spike protein, meaning that the vaccine will still have an effect. Could it be less of an effect? Yes. How much less? We don't know. Could it be effective for a shorter period of time? Yes, that's possible too. But for the vaccine to become totally ineffective, we would probably have to see mutations all along that spike protein. And remember that one of the greatest benefits right now that we're seeing of the mRNA vaccines is that it is completely preventing death and very severe infection. So to the extent that we are able to prevent death and very severe infection and also prevent the rapid spread of COVID-19, the fact that it may be a little bit less effective against the variants will be that much less relevant. With improved sequencing and hopefully a coordinated strategy for sequencing in this country, we will also be able to get ahead of this issue and be able to identify those variants in advance, enough in advance to update the vaccine. The other good news is that at least with the mRNA vaccines, we already have the basic platform needed, and the manufacturers can basically just pop in a new sequence whenever that's needed. When will it be needed? Again, we don't know that for sure, but Moderna has already announced that it will be putting forward a booster candidate against the emerging South African variant just to be on the safe side. So, will we need boosters from time to time in the future? That is completely possible. Will the COVID vaccine end up being a yearly thing like the flu vaccine? Maybe. It's still hard to say. Or will it maybe be like a combination vaccine in the future where it's targeting multiple variants? Yes, perhaps. At least until we're able to get this thing down to a controllable level, we will need to keep pursuing it at every step and in every way we know how. Because the biggest problem we still have is that here in the United States, we have not been able to get a handle on this pandemic since the day it started. We have been playing some kind of catch up basically since the beginning. So now that we have types that might be more contagious, what does that mean? Do we need to do anything differently? Well, the way I see it, COVID has been winning this whole time. We have been doing our calculations to try to stay ahead of it, and we've been taking the precautions we know how to take. So, with more contagious strains, this doesn't really change any of those fundamentals. It just might change the math we've been working with. And frankly, our math hasn't been that great so far, but now I think it would be wisest to double down. For example, perhaps the mask protection we have been recommending isn't enough now, and we need to upgrade to protect ourselves better since we're dealing with strains that are more contagious. So wear a multi-layer mask, not a single layer mask. Or if you know you need to be someplace where you'll likely be exposed, like if you are in an essential line of work with the public, you may need an N95. Also, perhaps 6 feet isn't far enough now, and maybe we'll need to have even greater physical distancing. Definitely, the mixing that folks have been doing between households was leading to infections before. Well, this will become an even greater risk and a greater concern as more contagious strains take hold. And it is quite possible that the percentage of people we need to get vaccinated in order to achieve herd immunity may be higher than we originally thought because we have a more contagious strain to contend with and it is spreading more readily. At this point, the best strategy we seem to have here is to extinguish the fire that is burning out of control by vaccinating as much of the population as possible. I truly wish there was another viable solution, but I am just not seeing it. And the virus is beating us at every other turn. If enough people are vaccinated, transmission will slow down, and there will be far less opportunities for replication, which in turn should mean fewer opportunities for more mutations and more variants. So, as before, the best tools we have to fight this pandemic, now in addition to the vaccine, are to mask, distance, test, isolate, and contact trace. This is true now more than ever. Don't share your air, mask up, space out. Always protect your elders and those with underlying conditions. If you think you were exposed, don't go to work. Don't gather. Isolate yourself. Get tested in 5 to 8 days. If you have symptoms, get tested right away. Continue to isolate until you get your results. Take a multivitamin supplement and consider additional vitamin D supplementation. This concludes today's People's Health Briefing. Thank you for joining us. Please tune in next Tuesday at 10 a.m. See you then.